Top Med Talk.
Welcome to Top Med Talk, the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. Stand by for a healthy conversation. But first, the 2026 International Practicum on Cardiopulmonary Exercise Testing will be held from September the 16th to the 18th of this year. It is organised by iPoets, the International Perioperative Testing and Training Society. Come and join us at this premier educational event designed for clinicians, scientists and healthcare professionals interested in sport, exercise and perioperative medicine. Check out ebpom.org for the best prices and information now. That's ebpom.org. And remember, this is an International Perioperative Testing and Training Society accredited event. So when you attend, you can get your iPoets accreditation showing that you are a practitioner who has reached a high standardized level of competence in performing and interpreting cardiopulmonary exercise testing for patients preparing for major surgery. Check out ebpom.org now.
Hello and welcome to Top Med Talk. We're coming to you live from Rotterdam in the Netherlands, the annual scientific meeting of the European Society of Anaesthesiology and Intensive Care, Euroanaesthesia 2026. I'm Kate Leslie, I'm your host, and I'm here with my co-host Andy Cumpstey.
Hi Kate, great to be back.
How are you enjoying Rotterdam?
It's been a really good couple of days. I have to confess Rotterdam is not somewhere I've been to before, but we've had some really interesting social evenings. We were on the SS Rotterdam last night and we've been out exploring the city and other things on other evenings, and the scientific programme's been fantastic. I think there's over 3,000 people here presenting and sharing their work from around the world.
And yesterday we were podcasting while they were simulating an industrial accident a couple of metres away.
People walking past us with oxygen cylinders and all covered in their blood makeup, body parts hanging off that were all fake. Quite an interesting experience podcasting with that behind us, wasn't it?
It was.
Yeah.
So this afternoon there's a sort of landmark or featured lecture, Hot Topics in General Anaesthesiology, which happens every year at ISAIC meeting. And we're lucky enough to have the two speakers, Laszlo and Hugh. Laszlo, would you like to introduce yourself?
My name is Laszlo Vutskits. I'm based in Geneva, Switzerland. I'm head of pediatric anesthesia there. Deputy Editor of Anesthesiology and Editor-in-Chief of Pediatric Anesthesia.
Excellent. And Hugh?
Hugh Hemmings, Chair of Anesthesiology at New York Presbyterian, Weill Cornell Medical Center in New York, and also Editor-in-Chief of the British Journal of Anesthesia.
Welcome. So, looking forward to your session this afternoon tremendously. Why don't we start with you, Laszlo? You're going to talk about mitochondria, and that's something that my co-host Andy Cumpstey knows more about than me, I'm sure.
Yeah, I picked this paper. Actually, I picked two papers about that we have published in the June issue of Anesthesiology. And it's a long story, like editorial-wise as well, because we were contacted by the Chilean Society of Anesthesia and the Chilean Ministry of Health like 8 months ago, where they told us that they have a couple of cases where apparently healthy kids went for minor surgical procedures with anesthesia and they had devastating outcomes. So they wanted to have a case series papers. We didn't have more information at that time, but obviously over the last, let's say, 12 months in the pediatric anesthesia community, we had more and more information that there were here and there some kids with anesthesia for minor surgery with devastating outcomes without knowing more. So we were interested about this Chilean data set or paper. So we asked them to provide us with some data to see what we can do. And as you can imagine, obviously we didn't have much data. So that data set ended up like a letter to the editor, because for obvious reasons, probably many of these are still under investigation. We couldn't have a very detailed description of those patients. At the same time, from Spain, we also received a very nice work where there were 7 other patients with devastating outcomes. And in that paper, they also did genetic testing, quite detailed genetic testing. And what was interesting, they went further into mechanistic insights.
So for people listening at home, they might be saying, well, why do I need to know about a rare variant in Chile? But this isn't limited to, I mean, Hugh mentioned this earlier, but before we came online, there's other conditions like this or other situations like this that might affect people around the world. But what's unique or interesting about this particular variant in Chile?
Well, the thing is that, I mean, as anesthesiologists, we are all aware of all these problems that we can encounter with mitochondrial disease. There is a huge amount of data of the majority of people with mitochondrial disease have a phenotype in one way or another. And we know, or at least we have some hints that they may have problems, and we could do investigations before. The problem here was that, and then if we get more into how the genetic analysis was done, I can explain that a bit more. The problem here was that you have healthy kids without any pathologies, you do anesthesia, short anesthesia for minor surgery, and then you can't wake up the child, or when wakes up, have seizures, have paralysis, or even there were children who were dead in the first 48 hours within surgery.
So totally devastating.
That's terrible.
Awful.
Mm.
And what do we know about this now, and are we getting any closer to being able to predict who has this variation and how we should treat them differently?
Well, we are far from knowing everything, but what we start to know, so in that particular Spanish paper I will present in this hot topic session, so they did a very detailed exome sequencing, because in the exome you also have genes that can prone you to mitochondrial disease. They didn't find anything. And then they found that these 7 patients and the mothers in the mitochondrial DNA sequencing, they shared the same haplotype. And in this haplotype, there were 30-some mutations. Those are known, and those define a specific haplotype, which they can trace back to a specific region of Venezuela. And they had, to make a long story short, 2 mutations, those induced changes in mitochondrial complex amino acid sequences. And one of those mutations basically induce a change which can destabilize mitochondrial complex 1, the ND4 subunit of mitochondrial complex 1, which is a major entry for the oxidative phosphorylative pathways.
So for the benefit of the listeners at home, again, just remind us, so complex 1's in the electron transport chain in the mitochondrial membrane. It's one of the 4 proteins that moves all the protons along before it binds with oxygen. But that's the first one, the sort of key part of that pathway, the major entry point, yeah. And that's where this mutation's active.
So one of those mutations is active there, and what's interesting that mutation, when they try to look, there obviously, fortunately we have mitochondrial databases, they couldn't find this specific mutation out of more than 300,000 mitochondria samples. So that's something that actually has never been found before, that particular mutation. The other mutation were found, it's a mitochondrial complex 3, but that particular one, which is on the ND4 subunit of mitochondrial complex 1, they found it in all 7 patients they described, and obviously in their mothers, as mitochondria is inherited via the mother. So that's why they thought that probably this specific mutation can be the culprit of that. And then what was extremely interesting after the genetic analysis, that they went further, they created cybrids. So what are cybrids? Cybrids are these cells. Basically, you can take from one cell just the mitochondria, you can deplete the mitochondria in another cell, and you can then fuse those cells, and you can create cells. You have, let's say, the maternal mitochondria with the mutation in another cell. Or you can also introduce different kind of mitochondrial mutations. What they did, they used these cybrids on top of the fact that they could also obtain fibroblast from one of the mother of these kids who had devastating outcome. And then they traced the oxidative phosphorylation upon sevoflurane exposure. And they found that when they have this mutation and not other non-mitochondrial mutation, oxidative phosphorylation is being shut down very, very fast after exposure in a petri dish, obviously, but to clinically relevant concentrations of sevoflurane. It's already terrible, but the good thing was that it's reversible. So when you remove sevoflurane, at least for short exposures, oxidative phosphorylation can recover. So it's a bit different than you have malignant hyperthermia, where you start something and that it goes along down along.
Interesting. So it's a reversible process. If you take the sevoflurane away, the problem resolves totally.
Well, in a petri dish at least, yes. Okay. So the data indicate that it's something that's not a covalent binding or irreversible binding to this complex.
And do we know specific to sevoflurane or specific to volatiles, or if we give these children a TIVA anesthetic, are we going to see the same problem? Or
that's where we have to be very, very careful, because in this particular paper, which so far is the only one, they also did propofol, exposure to propofol, but they didn't expose it to the propofol. We use it in the lipid solution. So they just took the formula of propofol and diluted it in saline. And what was interesting, that the propofol didn't affect oxidative phosphorylation compared to sevoflurane.
And how does the problem that sevoflurane creates translate into neurological problems?
Well, the thing is that basically what's happening, that you shut down oxidative phosphorylation, you shut down ATP production. That means that all of a sudden your cells do not produce energy and cannot use oxygen. That means that, for example, the brain, obviously one of the organs that will be the most sensitive, but some of these kids also had AKI and other problems. And within the brain, when you have, let's say, hypoxic lesion, very often it's the basal ganglia, parieto-occipital cortex, cerebellum, and the authors also present MRI images where the basal ganglia have these lesions.
And what age are the children that are affected by this problem?
So most of these were young adults, kids, but they had from the age of 7 till the age of 40. So it's not just the children. I think we are dealing with a situation where you have where you don't have any phenotype, but you only have a genetic mutation, and you could potentially be exposed at whatever age to sevoflurane, and you could have this devastating outcome. So it's not just related to children, probably because these were mostly children who were reported first. But obviously we don't know. We don't know, for example, the frequency of this mutation in the Venezuelan or in the general population. So there are many unknowns here.
And is the implication that the original source of this genetic mutation, that the woman who was the first person with this mutation, that happened relatively recently?
You can't say that. So it's very difficult to say, because if this mutation is, you don't have a phenotype.
A phenotype by meaning there's no symptoms or signs.
No symptoms or signs, then it can be here for generations. Sevoflurane is not that, especially in South America, it's not that old. They started to use it, let's say, 10 years ago, before it was halothane. I mean, I'm not sure that halothane would bind to the same way to mitochondrial complex 1. I don't know. So it's possible that it's around for a while. And what's interesting, there was one case report. Actually, it's not even DOI index. It's a report you can find on internet. A patient with ND4 mutation who developed ocular ophthalmoplegia. But that patient was never exposed to sevoflurane.
What do you think, Hugh?
Well, it's an important finding. I mean, it's great that they've identified the mutation. That was the next step. When it was first identified as a clinical syndrome, there was a lot of concern, obviously, because everybody who does pediatric anesthesia was worried. Could this happen to me? How can I prevent it? We had a lot of excitement about what should we be asking patients if they are of Venezuelan descent. Should that be part of our routine pre-anesthesia question? My reaction to that was, well, how deeply do you ask about malignant hyperthermia, which is probably more common? I mean, we don't know for sure, but it probably is. Again, that's one we can test for genetically if it were affordable and maybe more common, but there are more than one mutation there. My guess is there will probably be more than one mutation in complex 1, so it's probably going to be a similar scenario where, preoperative genetic screening routine, an affordable test is probably not in the near future. Someday when we can do exome sequencing of every patient before anesthesia, we'll know a lot more. So anyway, it's an important piece of data. I think from what we know, it's not terribly common, and there's concerningly not a lot you can do to protect yourself or the patient other than perhaps avoiding volatile anesthesia.
I fully agree with that. In mechanistic terms, the authors also said that although they identified the specific mutations, you never know how these mutations interact with the 37 other mutations. Those are not malign, how they interact together. The problem is in real life that now we start to have, and even I had a case, they called me from Paris 2 weeks ago, one of my colleagues. So she was taking care of a Venezuelan child. She was not very much aware of this, but the family came that they want mitochondrial testing before we do anesthesia because they heard about the story. So that's the tricky part, what you do. There are now statements from the ASA, SPA, SIA, WFSA. The problem is that all these statements, they can only point to the problem, but they cannot really say what to do. I do agree that probably avoid volatile anesthetics. Again, we don't even know if propofol at certain dosages, whatever, would be devastating as well. We don't have that much detailed clinical data on these patients so far.
There's another interesting part of this, which is the intersection with investigations of the mechanisms of anesthesia, because there are certain lines of research that suggest that complex 1 is an important target for producing the desirable effects of anesthesia. And these patients, I don't know about the Venezuelan cohort, but other patients with complex 1 mutations are hypersensitive to anesthetics, so the volatile anesthetics. So, at about a tenth the dose, they become completely anesthetized.
But what I understood from those studies is that they were exome mutations because some of the proteins in the mitochondria are synthesized by the exome DNA, not mitochondrial DNA.
You've got me on the details, but I do think you're right. I think it's an accessory protein that interacts with ND4 as a part of complex
You might have
1.
to explain that to our listeners, Hugh. So
It's another gene product that is interacting with complex 1.
Yeah, okay.
Yeah. So can I ask what my listeners might be thinking, how does interacting with this part of the mitochondria produce unconsciousness?
Kate, that is a really difficult question. I think,
but that's what you're saying, isn't it?
Yeah. Well, that's the question. That's why there's still a lot of controversy around how important this might be as a mechanism. But the idea is that, and this is based on some work by Phil Morgan, who actually has a lot of experience in anesthetizing patients with mitochondrial defects in Seattle, that what they found is that volatile anesthetics can interact with mitochondria to reduce the energy supply in the presynaptic nerve endings, and that impacts the release of neurotransmitters, so it can block neurotransmission.
That makes sense.
And that can lead to alterations in neuronal interactions, communication in the brain. And that, as best we know, that's related to anesthesia, which is a breakdown in communication between regions, most in the cortex and between the cortex and the thalamus, for example.
But isn't that going to happen in every cell in the body?
The mitochondrial effect would. So it would have other effects. I think, that's happening under anesthesia. Anesthesia, we use it to target consciousness, but there are a lot of other effects. Yeah.
You shut down in one way or another metabolism. So obviously you shut down in the cortex and subcortical structures that could at least participate to loss of consciousness. But again, there are many other data on ion channels, though these drugs acting on ion channels. It's also possible it's an interaction between the two. Yeah. It's difficult to say.
Wow. I think we better move from the in-depth, the mitochondria, to something much larger, Hugh, which is what you've been going to talk about at Hot Topics. Various terrific large guidelines and studies that have been published in the British Journal of Anaesthesia.
Yes, I was going to highlight, or I will highlight, a number of important papers in the British Journal of Anaesthesia this year. And one of the most important, we actually featured in a BJA panel yesterday at the meeting on the role of video laryngoscopy in airway management in 2026. So what is the impact of these new guidelines on how we manage difficult airways? And that paper was published, the guidelines were published in November at the World Airway Management Meeting, and simultaneously presented at the meeting and appearing in the British Journal of Anaesthesia, along with a special issue on airway management, which includes a trove of other really interesting articles related. And since we had a whole session on it yesterday, I do want to highlight it as an important paper without going into a lot of the detail. But one of the major take-home lessons is, and what the airway experts are telling us now, is that video laryngoscopy should be your first choice in tracheal intubation.
routine intubation.
tracheal intubation, and definitely in difficult, anticipated difficult intubation. Now, I think in practice, we're all quite far from there. And depending on where you are in the world, it's not even a reasonable possibility at this point. So I think we do have a ways to go and more work to be done. I think what we also heard at the session, and is also covered in some other guidelines and meta-analyses that were presented, is that the differences in success are not always statistically significant if you broadly compare video laryngoscopy to direct laryngoscopy. So the next level is to identify these subgroups where it may be actually, more demonstrably important. So that's sort of where that is. So I'm going to highlight that, plus a couple other features of that came out in these guidelines that are different. The last time these guidelines appeared was 2015. So it's been 10 years. The big changes in clinical practice have been in the real progress in video laryngoscopy, and also in apneic oxygenation and what they call peroxygenation as an approach during airway management.
So with high flow nasal oxygen devices.
Including, yes. But I think the substantive change, in my view, compared to my practice, is that in anticipated difficult airway, you should be administering oxygen both before induction of anesthesia, but throughout the intubation process, not just take the mask off and try to intubate. So one way would be through continuous nasal oxygenation or some other way. That's especially important in pediatrics where the margin of safety is a little less.
Laszlo's looking a little bit skeptical.
He's skeptical.
Let's start a discussion about.
I'm not sure we should really start a discussion on that, and I should be very careful what I'm saying because our pediatric guidelines came out last year about that, and actually I can say that with some of my colleagues we wrote an editorial against those guidelines. My take is, after 30 years of anesthesia practice, that I do use video laryngoscopy, obviously, like many people. I don't use it as a first choice unless I do the teaching activities. I think that to show clinically meaningful benefit, you can do it in an emergency department, in the NICU, PICU, where people don't intubate that much. But my take is if you have an appropriate anesthesia training, you can or you should handle normal laryngoscopy in normal situation, in most of the situation well. Where we are a bit worried that the new generations of anesthesiologists, especially in rich countries where you have video laryngoscopy everywhere, will not be familiar with the traditional laryngoscopy, and it's all already happening. In terms of apneic oxygenation, I think I fully agree with what you've said. I personally, even in neonates, don't do when it's the staff who is doing that, who is very familiar. We did a study where we showed that on average, in less than 20 seconds, the tube is in. Obviously, if it's a difficult airway, if you do it in the emergency department or the PICU, NICU, where people intubate less, I think the apneic oxygenation is definitely a thing. But again, that's my own viewpoint. Many of my older colleagues agree with that, but the new generation, the new guidelines are against my viewpoint.
I've been listening to the back catalogue of Top Med Talk, and back in 2018, after the release of one of the NAP projects, Tim Cook was talking with William Harrop Griffith. They were going to do a debate, and it was just like this, And Tim Cook said, you don't put a seatbelt on as you're careering towards a fatal accident. You put it on before you start the engine. That it's about the patient and their safety. It's not about us and our desire to do these procedures in a particular way. I thought it was quite a compelling argument.
But if you would say so, then you would say, with that, you would acknowledge that for 50 years, since we do normal laryngoscopy, we are very dangerous, which is not the case because most of the patients you intubate well. That's one thing. I'm nothing against video laryngoscopy. Again, I'm based in Europe. I'm traveling a lot in Eastern Europe as well. There are hospitals where you don't have video laryngoscopy neither. So, and you can find yourself easily in a situation where you will not have a video laryngoscope. So my personal viewpoint, which probably can be easily debated if you're an anesthesiologist, it's good to learn how to do laryngoscopy, traditional laryngoscopy.
You're a young person, Andy. What do you
I was just going
think?
to say, I'm looking forward to when we sit on this couch in 2 years' time and we're here discussing the mitochondrial genetic problems that are oxygen sensitive. And there's some of those up there as well. And there's good data on that. And we've been giving all these people high flow nasal oxygen for our pre-oxygenation and triggering mitochondrial problems there that we didn't know we've had before. So I think these things go around in circles. But I mean, I do use video laryngoscopy, but I sometimes look direct with the video blade. But I start with the video scope, and if I need to turn it on, it's there. As you say, the seatbelt analogy, why would I have it on the table next to me and have to change blade if I'm having difficulty? So I start with it, but you can still look direct.
It's the same argument as using ultrasound to put in an arterial line.
Yeah.
Like, I might need my radial artery for a dialysis shunt. I don't want someone to mess around. I want them to do it right the first time. The same as with laryngeal masks. The apparent, disappearance of bag mask ventilation skills. I don't think that's really panned out particularly. Anyway, it's a great discussion. What do you do, Hugh?
I think what this shows is that anaesthetists are very sensitive when you start talking about a technique that they all do on a regular basis, and everybody has their bias here. And when you propose any sort of change in the routine and something that we all think that we're expert in, it's a little uncomfortable for some people. And I think the data are not all in. I think there's still work to be done. I think the issue about what happens in parts of the world where you don't have access, and that question was asked at the World Airway Management meeting from the audience. It was a very good question for which they don't have a great answer, and it wasn't part of the guidelines. I think that one of the things that has to happen with perhaps all guidelines is how are they implemented in different parts of the world? Are we just interested in the safety of anesthesia in the first world? Is that our main focus? I think you come to a meeting like this and you have a very international audience. So these questions obviously come up, and I think that's why these meetings are important. It was raised at an international meeting when the guidelines were presented. The experts had been sitting around a table, in their first world hospital, developing these guidelines based on current technologies and science. It's not universally applicable, even though Tim Cook, as you said, is now promoting universal laryngoscopy, his kind of latest. Video laryngoscopy. Right?
I guess, though, one approach would be that people in middle and lower income countries can negotiate with their hospital administrators, saying, here is an international guideline that says this is safer. I remember during the pandemic, people were able to negotiate packages to introduce VL because of the need to get the intubation right the first time in COVID patients.
We've been through this journey before with other technological advances in anaesthesia. I mean, the oxygen saturation probe, which now is routine mandatory monitoring around the world for a long period of time, was not available in many places. But I think once it was added into a guideline, that definitely enabled that transition to move into.
And thanks to Lifebox, which was the WFSA thing.
And we'll see, there's a lot of innovation in COVID out of necessity. I think we'll see perhaps less expensive, more translatable versions of video laryngoscopy.
Agreed.
Who knows? 3D printing and a chip, maybe you can do it. I don't know. So I think that'll happen. And you're right. I think the guidelines will help motivate whoever's making the decisions about funding.
Brilliant. Well, on that note, thank you both for joining us. Thank you for sharing your insights, and we look forward to your session later. Thank you for listening at home. As always, you can find this episode and all our other episodes through our website. That's topmedtalk.com. There's over 2,000 episodes in that catalogue that Kate mentioned. Do go back, have a look at some of our older episodes, see how this debate's been changing over the years. We should say a huge thank you to Isaac for hosting us here again at Euroanaesthesia in Rotterdam. And of course, a big thank you to our annual sponsors. That's BD Advanced Patient Monitoring and GE Healthcare, who really do keep us on the road. And finally, please do find us on social media. We're on all the main channels. Hit like, hit subscribe. It really does make a difference. And share this with your friends. Thank you.
Cheers.
Top Med Talk.
And remember, the 2026 International Practicum on Cardiopulmonary Exercise Testing will be held from September the 16th to the 18th of this year. Come and join us at this premier educational event designed for clinicians, scientists and healthcare professionals interested in sport, exercise and perioperative medicine. Check out ebpom.org for the best prices and information now. That's ebpom.org.